So there are pediatricians all over the country who are providing excellent care to their patients, but one physician in particular has introduced an innovative new program which has been very successful in changing the way that care is delivered. I'm delighted to introduce Dr. Elizabeth Woods, who's going to describe the Community Asthma Initiative. Dr. Woods is a professor of pediatrics at the Boston Children's Hospital, and thank you so much.
It is a great honor to be here. I would like to thank Brookings for this forum, as well as our Community Asthma Initiative partners, staff, and families. Let me tell you about what we did at Boston Children's Hospital to provide an enhanced care to children with asthma. A community needs assessment was performed by the Office of Community Health at Boston Children's Hospital using a community participatory approach in 2005, which identified asthma as one of the top community concerns. In this process, asthma is found to be the leading cause of hospitalizations at Boston Children's, and 70% of the children came from 5 low-income neighboring communities. They were predominantly African American and Latino. The asthma hospitalization rates for African American and Latino youth were 4 to 5 times those for white children, and this suggested a major health disparity. The target population was initially identified as children 2 to 18 years of age from 4 zip code areas with high asthma rates during the pilot program that corresponded to Roxbury and Jamaica Plain communities of Boston, seen in the yellow hashed areas on the map. Children served by the program were compared to 4 demographically similar zip code communities of North and South Dorchester, seen in orange, during the pilot program, though now we serve most of the low-income communities of Boston. Patients are identified through logs of emergency department visits, admissions at the time of an event, and we help connect patients back to their primary care sites. In addition, we now accept referrals from primary care providers for patients with similarly poorly controlled asthma that they identify. Data are provided by parents as part of clinical care, and we're approved for access to the hospital administrative data for Community Asthma Initiative patients and patients from the comparison community for cost analyses. The Community Asthma Initiative provides care coordination by bilingual and/or bicultural nurses and community health workers. They work with families to establish their own goals for asthma control. They identify barriers to good control through tailored education about asthma and medications. They discuss medication adherence. They investigate the home and school triggers and discuss the family's access to insurance and issues with co-payments. Environmental assessment and remediation is provided, including materials such as vacuum cleaners, bedding and casings, and integrated pest management materials tailored to the needs of the family. The Community Asthma Initiative provides connections to community resources such as housing advocacy and inspectional services, especially to the Boston Public Health Commission's Breathe Easy at Home program and other resources. We work closely with partners from the city, state, and state public health and numerous community agencies around healthy housing and building a business case for sustainable funding. Up until now, the program has been funded through grants, philanthropy, and internal support, and we're grateful to our funders, including the Health Resources and Actions Center for Medicaid and Medicare Services Innovation Grant, Maternal and Child Health Bureau's Healthy Tomorrows and Leadership in Adolescent Health Grants, the CDC REACH US program, the American Academy of Pediatrics, and several other smaller foundations, as well as the Office of Community Health at Boston Children's. You may want to see our website for links to our partners. So now I will tell you about our findings. To date, we've served 1,361 patients and families. 77% of the families received home visits by nurses and/or community health workers. The average age of our patients is 7 years old. 45% are Latino, 47% are African American, 23% of parents are primarily Spanish speaking. 63% have an annual household income of less than $25,000 a year, and the group in the next income bracket have a particularly hard time with copays. And 75% have Medicaid, which is Massachusetts. In Massachusetts, it's called Mass Health. We collected data at baseline, 6 months, and 12 months after enrollment and found highly significant improvements in health outcomes. There was a 57% decrease in the percent of patients with any, one or more, emergency department visits, and 80% decrease in the percent of patients with any admissions due to asthma at 12 months follow-up. Similarly, there was a 43% reduction in patients with any missed school days and 51% reduction in parents with any missed work days due to asthma. This is an important slide that we really want to pause on and think about. On this side, you see the Community Asthma Initiative patients and the comparison population. It looks at the average cost per patient for the Community Asthma Initiative patients in blue compared to two similar communities, as we discussed, that were not served in the initial pilot using hospital administrative data. The Community Asthma Initiative patients have higher asthma-related costs initially because we do triage our patients and serve those with intensive care admissions first, then regular medical admissions, and then those with 2 emergency department visits, and then those with 1. It's important to see that the reduction in costs for the Community Asthma Initiative patients exceeds the reduction for the comparison community and continues to decline. In the second year, even though we serve patients primarily just for 1 year. This is presumably due to the continued use of controller medications and reductions in allergens in the home. The return on investment for the program is 1.46, indicating that for every dollar spent on the program, $1.46 are saved by insurers and society. We adjust for the cost of missed school days and missed work days, and there's a 1.73 social return on investment. Importantly, the cost per patient served has been optimized over the years and is now down to $2,060 per patient using a nurse-supervised community health worker model. However, there is an average of 2 family members with asthma yielding a cost of $1,000 per family members. However, don't forget that half of the family members may well be adults and are not likely to be covered by a pediatric program. In conclusion, the program needs to transition from funding primarily from grants, philanthropy, and internal support to more sustainable funding mechanisms. As we replicate the model, the emphasis needs to be to work with primary care sites where funding may be provided in part by insurers. As we work with medical homes, population management mechanisms need to be in place to rapidly identify patients with poorly controlled asthma to provide direct referrals to the community health workers, even if the patients are not well known by their clinicians and are not even necessarily accessing care well. The Community Asthma Initiative needs to work with insurers to pilot and test funding mechanisms, and this may vary from insurer to insurer. As an example of innovative funding models, we're thrilled that you'll be hearing more about the Massachusetts Medicaid bundled payment pilot later this morning, which we hope to participate in.